Hello, I am Dr. Sourabh Patwardhan from Nanda Deepai Hospital and Phaco Training Center, and I am going to present another audited video. So, what you can do better. So, this is my colleague surgeon who is going to operate on a dense cataract, a mature cataract with shallow anterior chamber, as you can see here. Now, to begin with, I would like to fill the anterior chamber with BSS properly, so the anterior chamber deepens a bit before I take my main incision, because sometimes you may damage the anterior capsule if the anterior chamber is too shallow, and when you are entering with the keratome, it might hit the anterior capsule. This is the Hylucoat, a combination of hyaluronate and chondroitin, which is being used, which is excellent for these kind of cases because it's a heavy OVD. Now this is a intumescent cataract. You can see the liquefied cortex. This is a old patient, so I don't expect the anterior capsule to be too elastic. So the chances of Argentinian flag is quite less here, but still, because the good OVD was used, it is even reduced further. Now you just saw what happened here. Whenever we have any cannula, whether it is visco or VSS cannula, which is not used, you have to first flush a little bit outside the eye so that you don't get this air in the anterior chamber. So when the air goes in, it's quite annoying because it disturbs you in visualization, and then it is better to just aspirate it out so that you get proper access to the anterior chamber visually. And now the surgeon is performing the cortex aspiration, but I think the cannula should go inside to aspirate it, not from the first incision itself. And now she is performing peripheral stroking of the cortex so that the fluid clefts which are there are flattened. So what we want at the end is a flattened anterior capsule in such cases. But I think again those attempts are little bit hesitant attempts, so it should be done properly. There is no risk of extension when you are stroking the capsule from the periphery to the center. It is like milking it, so the fluid cortex which is inside there is equally distributed and the anterior capsule becomes flat. So I think all the steps being done are as per my teaching, but I think every step should be or can be done even better. I think the reason behind not being able to do each and every step with perfection is that hesitancy that something might go wrong while doing the cortex aspiration or while peripheral stroking of the capsule. Now the Capsulorhexis has been started using the 26 gauge cystotome, and I am already worried. If you see on the nasal side, there are already some clefts which are seen. These are not flattened out completely. So I can just say that the surgeon may face some issues in that region, should be more careful, and it could be done even right now, that you can just aspirate out some of the fluid from that area, or you can flatten it out to avoid any issues in that area. Now the rhexis is going on nicely. The rule of center of triangle, as I have described, is being followed very well, holding the flap right at the imaginary triangle at the capsular tear, the triangle of around 1 to 1.5 millimeter, and holding the capsule right at the center. And now, as you can see here, the capsular tear is trying to move away because of those fluid clefts over there. So the anterior capsule was more convex there, and the vectoral forces started pulling the tear outside. Now good thing is that surgeon noticed it right now and tried to fill the OVD again so that to deepen the anterior chamber, but good thing is that it was not overdone. But it is better idea to flatten the flap here and then try the Dr. Little's maneuver to bring that Capsulorhexis in, but the surgeon decided to just push the capsular flap ahead. I think this should have been avoided. and as anticipated, the Capsulorhexis keep going out. Now the savior here is the good OVD. Because of that, the tear has not gone in the periphery. Now it is already in the zonules, as you can see the resistance that was felt. And now this is right time to use the forceps and pull it inside. We call it quick pull maneuver, and good to go from the side incision as the surgeon is doing right now. Hold the tear or the flap and just pull it centrally so that the Capsulorhexis tear comes in. All these maneuvers were helped by the good OVD, but I think, as I mentioned earlier, that everything could have been done better so as to avoid these, I would say, increase heartbeats at the end. Now the chop is being made. Phaco has started. Surgeon is going to use the combination of longitudinal and torsional phaco here, and attempt has been made to do stop and chop, but I would say it was not a successful attempt. So what were the reasons? First thing is that for stop and chop, I think it is better to have a deeper trench so that you weaken the nucleus significantly, so when you chop it cracks it into two halves easily. Second thing is that for denser nucleus it is better to have a exposed tip of at least 1 millimeter. So when you bury that tip inside the nucleus, you get a good hold, good purchase of the nucleus, and then you can chop the nucleus easily. Here the exposed tip was small. And high vacuum has to be maintained till the chop is completed. If you go back and see, you will find that after burying the tip, the surgeon just released the foot switch, so the vacuum decreased from 400 to 150, and that led to rotation of the nucleus because the hold was not good now. So after that unsuccessful attempt, good thing is that the surgeon knew that she should not go further with the chopping unless the nucleus is cracked into two half. So then again the fallback technique used here is the trench divide, and here because it is a dense nucleus we should have a deep trench going to at least 80% of the depth, and then both the instruments should be deep enough to crack. Now here that crack was achieved partially in the proximal part, as you can see. I would have loved to complete the crack on both halves so that it's completely free from each other, but the surgeon decided to chop the pieces into small parts now and did it quite well. Here the first chop has been done. Again you can see that after getting the occlusion, the surgeon is releasing the foot switch a bit, and that's why the vacuum is dropping down to 250 to 280 to sometimes 150, and that's not giving a good hold over the nucleus as the surgeon would like. Of course the chops were still possible. You can see that again the vacuum dropped down after the initial full vacuum, and I think very good technique of multi-level chopping was demonstrated here. So I think everything is going nicely, but the surgeon can do better by improving the foot switch control so that the vacuum is maintained when the chopping is going on. That gives a good hold over the nucleus so that you can chop easily and quickly. The last, I think, chop which is being made, I think wonderfully done. And what is good about this surgery is that the surgeon never tried to push the nucleus against the bag or the posterior capsule. The surgeon never did any very harsh maneuvers even during the trench divide, where the division was done with minimal stretching of the nucleus, which is excellent. And now the quadrant removal, surgeon is using the bevel down technique, and you can see some bubbles there. You can just keep watch on the bubbles so that to know whether the viscoelastic has been washed off or not. Using the bevel down technique here and using the combination of the longitudinal 25 millisecond burst and torsional 40 millisecond burst here, so as to minimize the repulsion, also to avoid clogging of the phaco tip, because sometimes if you use only torsional for these dense cataract, the tip may get clogged. So the half nucleus has been emulsified already, And this is a nice way to go further to replenish the OVD so that your endothelium is well protected and you can have very clear cornea in the post-operative period. Now what surgeon has done, you can notice that the vacuum has been decreased further to 300 because now the surgeon is approaching the remaining pieces, the last piece. It is being further being reduced to 250, and that's a good way to achieve very stable chamber at the end, very safe phacoemulsification. Your complication rates are going to go down if you use this technique of reducing vacuum at the end, and you can see how stable the anterior chamber is. There are no fluctuations at all. The surgeon kept the phaco tip right at the center. So excellent surgery done, and we are expecting, and we also saw that the post-operatively cornea was crystal clear. In this case, patient enjoyed some great vision. But of course, even with the amazing outcome, you can see that the surgeon can still do few things better. If you would like to get your surgeries audited, do send me your surgeries and I will review and publish them. Thank you so much.